There we go. All right. We'll start with the heads first, and then we'll move to the slides. All right, it's about time to get started. Oh, I'm echoing. Hold on, I gotta mute. Okay, gang. Just 6 people are watching now, so I guess we can get started. Hi, everyone. This is Greg Titus from FinStream. I'm here with my partner, Bob Powell, and our guest, Jae Oh. Bob, you want to tell everybody who Jae is if they don't know already?
Jae is a longtime friend, but more than that, he's a Medicare health insurance expert. He's the author of, there you are, Maximize Your Medicare. And he's a education fellow at the Alliance for Lifetime Income. Jae and I have done videos for over 5, 7, 8, I forget how many years now, Jae. But
I count them in Bob years.
But from my perspective, the conversations that I've had with Jae over the years have been especially enlightening and helpful to our readers and viewers who are interested in learning about all things Medicare, all things Affordable Care Act, all things health insurance, and the intersection of those things with financial planning. And so without further ado, Jae, turn it over to you.
Well, Bob, thank you for having me. And I want to make sure that I'm broadcasting here today. Greg, are we broadcasting correctly here?
Yeah, we are. The chat that you just posted, though, if you could post that in YouTube.
You're presuming technological expertise. It's fine.
I'll paste it over there.
It's totally fine. Well, thank you for having me. So this is the presentation. And so the presentation is showing, is it right? Just making sure.
It is now.
Yeah. Okay, there we go. There, that's better. Zooming out away from me, making me smaller in appearance is always a positive thing. So I want to make sure. This is the presentation I've delivered to countless numbers of audiences. And it's for newcomers and for those people who are returning. In the chat, I put, and there's a QR code. This is a newsletter that I run, that I'm the sole author, talking about different topics and really just trying to clarify certain matters which can be confusing. The language, the noise is deafening, certainly about healthcare cost planning and its importance in people's financial plans. So in there, I try to make fun largely at myself because that's one of my great pastimes. And in addition to that, though, making comments to just try to separate the signal from the noise. I try to do it in everyday language because while, like Bob pointed out, at the Alliance for Lifetime Income, for example, we have academic heavyweights for sure. I'm just a guy and able to try to distill it into language everyone can understand. Today's not financial advice. So we have a society, I don't think we need any introduction. We won't beat it with a dead horse. We have a situation where, he said, she said, the game of telephone exists. I'm qualified and permissioned to give direct financial advice. That said, especially on these matters nationwide, which we do. But today in this presentation, this recording, however you're digesting it, isn't financial advice. This is some stuff about me which is not particularly interesting, meaning that other than the takeaway being that I'm going to try to speak in everyday language that everyone can understand. That is, however, underneath the hood is very complicated set of conditions, information. So while I'm going to be trying to speak casually and things like that, the word choice here is not random. I'm going to be using very specific terms. People call me annoying as a result of that, as a personality trait. I call that a feature. We won't settle that here today. Before we get started, just some basics, which is if we get the right starting point, I'm convinced that everyday people, everyone, and by everyday people, I'm talking about people who are not spending their time reading through Medicare manuals, health insurance manuals, finance books. What I'm talking about, though, is if we have a good starting point, we can try to filter out the deafening noise. And for me, right out of the gate is health insurance is not healthcare. Health insurance, financial contract, written by lawyers. The word choice there is specific. This is why going to Applebee's and talking to your buddies and just using around terms kind of, sort of, just doesn't work. Murphy's Law, everyone knows it, right? Which is that something goes wrong, it'll be about that term that you were having when you were having endless appetizers, almost for sure, right? We don't need any of a book to tell us this. This is what happens. From there, once you get to that insurance is a financial contract, it is a calculated result. And that is based in probability. I tell people in public, like today, right? Job number one for a carrier is to have them numbers and their probability right. We can have a lot of different other messages, and those are going to be true, that they're looking out for your overall well-being. All of that is true, but this is the starting point, meaning that the shareholders, the stakeholders, I should say, of the carriers are also under tremendous pressure. And we have this because you can see simple examples. Easiest one, and we'll get to the questions and other questions, is in Minnesota, the second largest carrier of Medicare Advantage is leaving entirely. So you can understand, how does the combination of Medicare Advantage is a scam or other type of negative noise, and also yet the carriers are leaving because of competitive pressure. So as a result, these two can't coexist. And so you can see it right away. I want to be positive, which is, and this is also true, because it's a financial contract, the rules for entry, the rules for exit are known. And if I had to tell people, they are wildly in the buyer's favor. It may not feel like it, but in fact, the buyer is in control here. If you understand the rules, you will understand that the rules are ultimately in the buyer's favor. And the last point is that, as Bob mentioned, I'm education fellow at the Alliance for Lifetime Income. The importance here of healthcare cost planning, long-term care, which is beyond today, for example, these have not only concerns about how you're going to access your coverage, access your care, your benefits, but it has very much to do with the cost of managing it. And while all of the headlines are on income, I would prefer the phrase net income. Net income means that after expenses, and that is definitely one of the objectives of the reasons that I wrote Maximize Your Medicare. All of that set up, and we'll dive straight into Medicare now.
Yeah, let's just make sure everybody knows to please ask questions in the chat.
Oh, sure.
And Jay will try to answer as many as he can. If we run over, we can do this again soon.
It's cumulative too. I always tell people, if you've not asked, I promise you some other member of the audience has the same question.
Yeah.
So for me, the starting point then is eligibility, enrollment, and for you to understand it correctly. And rather than give you a bunch of bullet points, let's just use this card. What do we know about John Smith? John Smith turned 65 in the base case from March 2nd through March 31st of 2016. So a couple of things to note from this card. Number one is he qualifies if he's paid for 10 years of Social Security administration. There's a Medicare tax, a separate line item, which is withheld from your paycheck. If you've paid for 10 years, 40 quarters of credit is what it's called by SSA, then you qualify for this card. If you're married to someone who has paid into the system for that period of time, you also qualify. If you're the widow and your deceased spouse has paid, you qualify. If you're divorced and that ex-spouse has paid in there and you've been married for longer than a year, you qualify. So I'm not concerned about your qualification other than the fact about the 40 quarters of credit. I was very careful, like I said, which is that March 2nd. And so what you have here is the exception. The exception is, and I'm skipping here because I'm talking off the top of my head. The slides are in order. I don't have a script. So there is an exception, which is if you're born prior month. And now this example that I've highlighted here by the arrow, yes, the arrow works, which is that if you're a New Year's Day baby, your eligibility is December 1st. I'm going to go back here for just a moment. The first day, let's just take the base case. You're born on March 15th. You turn 65, March 15th of 2016. The first day that you can apply for Medicare is 3 months prior to this date. So that means 2/1/12. March 1st, 2015, the person could have applied, John Smith could have applied for Medicare. It doesn't become effective until March of 2016, but he could have applied. The reason I'm swerving to make this point is I highly encourage people to do this part A at the minimum as on this first date. The practical reality is one of the slides that I've cut out as a result of time, in the interest of time, is that delaying any step here doesn't get you anything. You don't get better benefits. You don't get lower prices. All you get is delays because there are steps that you need that we don't control. Because you're going to press send and it's going to go to the government who's got to confirm your 40 quarters of credit. Perhaps later you've decided to work beyond 65. We may have additional forms. We'll get to that in a moment. There are some situations where you can qualify for Medicare prior to the age of 65, and this top panel describes it, gives you an overview of it. End-stage renal disease. So if you have ESRD and you require dialysis, a delay exists. Beyond today is a very long, complicated list of situations. In other words, did you have a kidney transplant? How, and then are you now only on just life is returned to air quotes normal? Then you have a different part, a different like subsection variation of Medicare. The second, so in other words, each one of these has to be handled with extreme care, but they do exist. The second one here is ALS, Lou Gehrig's, otherwise known as Lou Gehrig's disease. Now, even here, it looks simple, obvious, but it's not. Meaning that with no delay, that is true. There's no waiting period. But you must also simultaneously not be working and also approved for SSDI, which is Social Security Disability Insurance benefits. So, for example, let's say you're 40 and you were diagnosed with ALS, but you continue to work because you're able to do so, you don't qualify here. You have to not only be diagnosed, but you also must have applied for and been approved for Social Security disability. The third point is the predominant, the most commonly found one for people that qualify prior to 65, which is you've received SSDI benefits for a period of 24 months. So now this explains why when you go on your interstate, there is Social Security Disability Attorney billboards. The process is complicated. You may know that there are court hearings, there's applications, denials. I'm not an attorney. My point is here, once approved, you may be assigned a date that was in the past. So that counts towards this counter of 24 months. So the reality is the judge could rule, oh, you were actually effective, should have been effective 20 months ago, in which case you would only need 4 actual payments. And then the catch-up payment, that catch-up payment would have represented some of these 24 months. In order to apply and the enrollment steps here, I just highlighted some of the steps and some of the complications here. So the top row is to understand that Social Security Administration is the party that determines your eligibility. They're also the party that determines, along with the IRS, whether or not you will be assessed IRMAA, something that we'll touch on later. You can and probably should apply on SSA.gov. As you know, as a result of the pandemic, in-person appointments at Social Security Administration office is becoming more complicated. Sometimes and so now you can see what I'm saying, which is I said that you can do this on December. Well, now I'm going to go into my Social Security Administration office to apply. Well, now there's a 6-week waiting period. And so now this types of scenarios exist, which is why I encourage people to prepare for knowing about the fact that December 1st is the first day that you can press send. And I use press send as to say that you can electronically apply for Medicare. Note that you do not have to be receiving Social Security benefits in order to have an SSA account, or you also don't need that to receive benefits in order to apply for Medicare by itself. You can do so. The second box here, which is in this top row, is some technical terms of names of forms. So this applies for people who are working full-time and have not enrolled in Medicare when turning 65. So you work for a Fortune 100 company, you are insured and covered by your employer. You can delay enrollment in Medicare. We will get to the delay and the absence of penalties in this instance. Now, this has to also be handled with care because there is 40B, which is to turn on Part B. There's L564, which is the form you need from your employer. And now this is what I'm saying about delay. Now you can easily see it. HR people are overloaded with the many, many different tasks that they have at their everyday job. Now there's a delay. Generally speaking, and not on this, but only here on this broadcast, is the fact that I generally encourage people to fax to the local office. There's a local SSA office. There's a federal SSA fax number. I generally, for our clients here that I help, what I do is I manage the entirety, of course, but my point is I ask our clients to retrieve the local fax number. And the other reason for fax rather than mail, of course, is the fact that there's a date and time stamp. Just in case the fax gets left on the floor or someone spills a cup of coffee on it. And the implication of that, as you could probably guess, and the reason that I've slowed down here slightly, is the fact that we don't have a systematic prediction of how long this will take. I don't, even when this happens, meaning that you allow on-time enrollment from location to location, I cannot precisely tell this is going to take you 72 hours. I've seen it take less than a week. I've seen it take 5 weeks. So this pretty unsettling, right? Because now you're behind. Why are you behind? Because you thought you were born in April. So you thought your April 1st, you thought your enrollment date was January 1st, you didn't know what the exception that I just mentioned. So now you're a month behind. You wait for 6 months for an appointment, or you send a fax and you have these other steps. And now the 3 months evaporates. So of course, this then becomes, self-evident that if we have the tasks in a row, that right away we'll know. Two other points quickly here, which is that we need proof of prior insurance. So if you're working and you retire, you'll want to have the explanation of benefits or the summary of benefits. Because at some point in time, if there's some controversy or some question asked by the carrier, you'll want to have written proof that you've had not only health insurance, but separately that you've had prescription drug benefits that qualified as credible coverage. In other words, at least as good as Medicare. That is a written statement, a written determination that your employer-sponsored plan will have. The nuance here is that it looks like this is all wrapped in one. It's easy to think that. Remember when I said it was complicated at the very beginning? The reason here is the reality is even on group plans that you can pick, the employer can pick health plan and a la carte the prescription drug plan. And while it's uncommon, it's not unheard of, which is that the prescription drug benefits not qualify for one reason or another. Were there questions here? I see some flashing here or shall I just proceed?
No, we could take a question. There's at least one in the chat that I know of.
Okay, it's totally fine. I'm happy to answer as we go. Not a problem.
Yeah. Bob, you want to take it?
Sure. So it reads, my wife just received her annual notice of change letter through her Minnesota Blue Cross Blue Shield. The Medicare Blue Premium RX standalone Part D plan will not be offered in 2026. She has original Medicare with a supplement. We don't want Medicare Advantage, and the alternative plans they list are all hooked up to a Medicare Advantage plan. Can't help but wonder if this is a backdoor way of getting unsuspecting original Medicare subscribers shifted to Advantage plans.
We will describe it in the future here. The bottom line for the question, though, is no. You do have the right to choose a different Part D plan. There will, as a person who is licensed in Minnesota, my mother lives in Minnesota, is the fact that I didn't absolutely know for sure that there are different standalone prescription plans other than Minnesota Blue Cross Blue Shield. So if I continue here on Part A, the number one question we always get is, can I delay? We get this worry. You saw some TikTok or you saw a YouTube short and there are endless penalties. They never expire. I'm going to explain to you what the penalties actually are and when you would face them. But what I thought about is the decision making. Most of what I'm saying here isn't really going to be in Medicare and You. I'm going to presume that you've received Medicare and You. Bob, you've committed it to memory from what I recall. So here, what I would say here is, in general, the base case is you do not delay. Base case. The reason it has no premium, if you qualify for Part A, then it not only has no premium, but it should coordinate with your employer-sponsored plan. When people with my background put in air quotes words like should, right, that should raise some concern or eyebrows at the minimum, which is that the coordination has to do with Carrier 1 and Carrier 2, one of which is now Medicare and your employer-sponsored plan, so you kind of get this. So while I hope it doesn't happen, then the coordination is seamless, it's sometimes eventful. Let me just kindly put it that way. And I've seen certain situations that somebody does hear a war story and they completely forego and don't apply for Part A at all, because Part A at a large employer is the secondary insurance. Your primary source of insurance at a large employer is Part A. There are exceptions here, and Medicare has a number of exceptions and ones that are becoming increasingly pertinent. The first one is HSA, which is no party can contribute to any HSA account and simultaneously be covered under Part A. Now that sounds very, innocent, meaning that, okay, well, I'm going to retire. I'm turning 65. I've stopped contributing to my HSA. By the way, the maximum, let's say mid-year, is the pro rata share of the annual maximum contribution limit. And, beyond today, that information is publicly available, but it's the pro rata share. So if you're turning 65 and you're going to go on to Medicare with an HSA for July 1, you get to your maximum is 50% of the annual maximum, representing the 6 months period. The hiccup is probably not the greatest word. The nuance here will happen in March. In March, I'm now turning 67 and I've now reached full retirement age and I've decided to retire. During this period, I've paid or received employer contributions toward my HSA. The issue here is that when this happens, they're going to turn on Part A prior, which makes it, in this instance, not March 1st. Let's say this is February, you decide that you're turning 65 and retire. FRA is going to be in March. So you decide to retire. You would think that this would read March. Part A line is going to read last year. Now, when I said things are complicated, we are not full control. I've seen errors in the exact month that I would not anticipate. And that is actually even the secondary problem. The primary issue is this date will read, let's just call it October 1, 2015. Well, last year, you've contributed to your HSA. You've now over-contributed into the HSA. And now you can't put yourself in the time capsule. And now you've got this tax matter, which is you've now created this backdating nuance, creating problems. So if you have, in this instance, I'm not a tax professional, I'm not an attorney. So this is one of those situations. Absolutely, you'll want to consider this. Part B. This is the predominant, of course. Once you get beyond the point that your employer doesn't contribute to an HSA, or you don't have a high deductible group plan, and you just continue, the question is Part B. There can be yes and no. Let's just go over yes. Can I delay? There's no penalty if you're covered as a full-time employee or you're a spouse of a full-time employee. Full-time employee for Medicare reasons is greater than 20 employees. If you're the spouse, like I said, no penalty. The controversy is the third bullet point, well beyond today, is if you work at a small employer, the employers can say, the carriers may say, look, in this instance, point to the Medicare manual, say, well, your small group plan is primary or Medicare is primary at a small employer, and the small group plan is secondary. But that is a different topic than whether or not you have a late enrollment penalty, which is quite subtle. meaning that the carrier can decide, look, you didn't have Part B, therefore I'm not going to cover you as the secondary. And there's a set of controversies there. You'll have to dig deep, but this can exist. But that is a separate topic from the idea that I'm now working I'm an auto mechanic and I decided to stop working, or no, I've decided to look at my employer sponsor plan and I'm being charged $800 a month. I'm now 66. I've decided to go to Medicare by myself. Medicare is not going to assign you a late enrollment penalty in that instance, which look related. They're actually separate. Very complicated. And so now you can understand why there can be controversy. Now you have the game of telephone. This is what happened. You ask a friend, this is what happened. This is what happened. This is what happened. And now you mix up two different challenges as if they were the same one. They're not. COBRA. So COBRA, under Medicare and Youth, it'll say COBRA can't be used. But the reality is that COBRA can be used, but only for 8 months. Meaning, let's just say for a moment that you are entitled to COBRA and your employer happens to, let's just say you have reduction in force. In this instance, sometimes the employer may, in certain instances that I've seen, real life ones, pay for COBRA. Well, you can take COBRA and delay enrollment in Part B without penalty, but only for 8 months. The reason I swerve out of my way here is a couple. Number one, I'm not concerned about the spouse because under COBRA, let's say you decided to go to Medicare, spouse covered under COBRA, even after employee has left. That is not the situation that I'm concerned about. The one that creates the challenges and the reasons that it can be rational that people gloss over is still superior. And I'm not good. We have hours of conversations here around COBRA, which is that you have a family insurance requirement. You don't get the advanced premium tax credit for your spouse or your children who are 25, your quintuplets at 25 years old, for example. You may want to have continuing access to COBRA because in your family, you've hit the out-of-pocket maximum. Now, your insurance would have zero out-of-pocket cost. Let's say you are the executive vice president of marketing. That accepting COBRA would start IRMAA at very, very high levels. So there can be these other combinations. It's kind of just, I understand this is an outlier, but it's kind of an example of never say never. That I encourage people to say, even if the conclusion is, let's not delay, let's just go directly to Part B and not take COBRA, that we'll just want to think through the financial planning implications all around. More subtle than you might be led to believe, or might have this impression that it exists. This is a list of no. If you've taken early retirement and you get retirement health benefits, your spouse is older, that spouse turns 65, that spouse doesn't have the right to delay, even if covered under the early retired employee. So let's just say you're a teacher. Thank you for doing great work. You've retired at 63. Your spouse turns 65. You accept your state's sponsored health insurance program as a public school teacher, retired teacher. This is a combination that exists very frequently. Your spouse turns 65, that spouse is not exempt. Second one, related to the last point from the prior slide is that COBRA after 8 months. If the 8 months expires and you have a gap beyond 8 months that you don't have health insurance, then you have to wait until the general election period, which is what used to be called that. We'll get to that, which is the first quarter. So you can understand what happens. You find out about this in February of in a particular year. You've got to wait 11 months until you have medical coverage at all. So expert kind of guidance, understanding of these details here, very important. I didn't say unreasonable or irrational because there can be large financial implications. I'm just saying that if we get too close to the line or misunderstood a detail, the impact on the other end can be expensive, either from cost or coverage, because then you will have, depending on how long this persists, then you can have the late enrollment penalty. Some people don't understand this exists. They're 62. Their spouse is 65. The employee waits till they're 65, then they're in for 3 years of Part B late enrollment penalties. This happens. Your takeaway really ultimately is this decision here is more complicated than it appears, and that the cost to the person, whether that be your emotional cost or your financial cost, your access to coverage cost, the cost is high. There are penalties which get all the news, and these are here. There are actually 3 levels. Part A we almost never hear of, but it does exist. 10% for twice as long as you have not correctly enrolled. For Part B, the prior example that I just said, it's in that particular instance, for every 12-month block, it's 20% of the then Part B premium. So you can understand if you have done this for 5 years, which I have seen, you've doubled your Part B premium. And this is not a one-time penalty. It never expires. Okay. You can fix it. You can fix it during the first quarter. And it will take which is certainly a correction here that the Medicare system has done. For Part D, which I'll describe in a little bit more later, 1% times the number of months that exceed 63 days times the national average. So you can have a discontinuation of credible coverage for 63 days. You could have, when you first turn 65, you can have 3 months. You could have this 63 days. But then once the Social Security Administration has determined they're going to count the number of months, you are going to have that penalty times the national average and never expires. You will receive these notices from Social Security Administration, and between it and the carrier, you'll have to pay for the late enrollment penalty on a rolling monthly basis.
So Jay, could I trouble you with a question on the Part B premium? Because if someone is subject to IRMAA, it'll be based on that elevated premium, but only for that 1 year period. And if their IRMAA changes in the following year, up or down, it'll be recalculated.
Right. Very, very complicated. Yes, that is the case.
Yeah.
So Part A, I'm going to rename these. No one asked Jay what I would call this, because this is slightly incomplete. I would call this facilities, to be candid, but it's fine. It's not the key thing here is Part A is inpatient stay, not outpatient. So you need to be coded by the Medicare system. There's Medicare, there is healthcare coding professions, jobs. You need to be inpatient status inside of hospital. Once that happens, then these are the costs. Please don't write them down, etc. These are well-known, commonly distributed. I'm going to be talking about what isn't in the new. Doesn't jump out, isn't fully explained here from this well-known, publicly available information. The implications first are that the deductible here says per benefit period. And when I describe Medicare, especially to newcomers, or for example, adult child who has nicely decided to intervene, or involuntarily had to intervene, can be the case, and get up to speed on Medicare. One of my main points is Medicare language may look the same. Medicare language doesn't necessarily work exactly the same. And here's one right here. It is very easy to gloss over benefit period as if that means calendar year. It doesn't. Benefit period, I would basically define as medical event. So if you have a medical reason for being admitted into a hospital in January, let's just call it left knee replacement. And then I had my gallbladder removed in July. Those are 2 medical events, 2 benefit periods, 2 deductibles. In theory, you are subject to an unlimited number of deductibles under Part A. That is possible. For example, if you go to the hospital inpatient and there you contract MRSA, that could be a second medical event, for example. Absolutely. These numbers here are for original Medicare. So these numbers for people who don't have any secondary insurance, they don't have Medicare Advantage, or they don't have Medicare Advantage. So if you don't have Medigap, if you don't have Medicare Advantage, this is the list of costs that you are subject to pay. Okay. Were there questions about it? There's usually some surprise whenever I say this. It's the negative to not being in public, where the audience, I can see people's reaction. For newcomers, this is a new piece of language for sure. Okay. If we speed along towards a skilled nursing facility care, what we have here is that this is known. Many people have seen or heard of it. First 20 days for zero, and then co-pays or co-insurance here, meaning that you pay the first $209 and then Medicare pays for the remainder. Beyond 100, you are responsible. Medicare is not long-term care. It should not be confused as long-term care. Medicaid is a separate thing. It is determined by your state. The quality of Medicare and how it accounts for your cost sharing responsibility will depend on the state. The key thing is over here in the second column, which is only after 3-day inpatient stay at a hospital. It looks like one criteria, it's 2. Years ago, Bob will remember that we spent a number of episodes talking about the fact that it's not only 3-day, but it is inpatient, meaning 2-day inpatient, you don't qualify. You're covered by Part B, not by Part A. 7-day outpatient stay, you don't qualify. So we'll get to the fix of that, which I would say anecdotally, we are not seeing this degree of controversy. And then, of course, when I was at my home city of Ann Arbor's library, one of the few times in public, one of the attendees was a medical professional and said, well, the Medicare system is auditing us all the time and switching the status. That goes in under the umbrella of things we don't control. Just understand your billing here can vary based on that. But again, this is something even beyond something that I would suggest for a short clip between Bob and myself. So, but certainly under things that we don't control. But just know in the backdrop, the CMS is auditing all the parties involved, and especially the hospital, especially hospitals. Inpatient psychiatric care, these are 100-day benefit for your lifetime. So I've already talked about benefit period. The fix to that strange combination of 3-day inpatient is observation status. That is the term for being outpatient. In general, the fix has been this third bullet point. Once you cross 2 midnights, the default position is that you're inpatient hospital stay. The nuance being my example, that's the reason I put it there or interjected with it, which is that the hospitals are being audited. You don't control whether or not your status was changed after the fact. Under skilled nursing facility, I'm going to just talk briefly about the second bullet point, which is this JMO. So I've spoken with lots of different adjacent professions, one of those being elder law attorneys. And they'll know what this is, JMO. This is the name of a class action lawsuit. It has to do with the fact that under original Medicare, the federal card, the question of whether or not you need to be improving in order to be covered by original Medicare. Commonly, this is understood as yes. The class action lawsuit conclusion is no. It went to the Supreme Court. So this is the source of a lot of confusion because if you are covered by a Medicare Advantage plan, the Medicare Advantage carrier is the arbiter of when you can receive benefits, when you do not. In that instance, we can't use this court case because of the fact it's about original Medicare, which has been replaced by the carrier and Medicare Advantage in that instance. Obviously, when someone's in a skilled nursing facility, then the entire extended family is under quite a lot of duress. A couple of videos on Jay's Corner on my YouTube channel are actually addressing all of the different adjacent challenges, both financial, emotional, preparation-wise about it. This is pretty deep in the weeds, I can accept. But you can understand that here, this does exist, that it is possible under original Medicare that you've been wrongly billed in the past. That's possible. Now for the easy part. Are there any more questions here? I'm going to continue on here. Part B, I wouldn't have called medical. I would have called services. So what you would expect. MRI, X-ray, blood test, durable medical equipment, office visit to your specialist or primary care physician. These are the well-known examples of services.
Yeah. Jay, I'll have a question to the law about you, and you may or may not be getting to this.
Sure.
We know that Medicare Part B premiums will escalate by 11% for 2026, or estimated to rise by that amount. And one of the reasons that I think the trustees gave was that hospitals are moving their services, or they're directing patients away from hospital to outpatient clinics, where now those costs are being borne by the Part B versus the Part A.
I would say, as an armchair economist or someone, watching the news and seeing this and knowing the mechanics of the way that health insurance works, that sounds credible to me. That does sound credible to me, which is, there is this, as I stated, and the conversation that I had from an attendee in Ann Arbor was about this exactly. It's referring to that exact example, which is, we're billing X, then the government is coming in and looking at all of our records and bills that they're sending. Well, the issue is that that's for inpatient hospitalization, not at Part B. So if I don't, just as a practical matter, as opposed to Bob watching to see how many, if I've eaten 10 green beans or, my full share, I'd rather him not watch. You can connect the dots there. Yeah. Right. So in other words, do I really want my parents to actually watch me do my homework? Or I can promise, I can tell you after the fact, my father was not impressed with the level of energy exerted.
Yeah.
So
for those listening, for me the takeaway message is your Part B premiums, at least according to the trustees report, are going to escalate much more than they did in the past, and the implication is your net Social Security benefit check might be lower as a result.
Which has been the case. I mean, maybe not to this degree, right? Meaning that it has been the case for years that you'd have COLA, which is determined by a calculation, right, of CPI. So that is known, and that Medicare premium has exceeded as a rate, the rate of increase of healthcare cost in the United States, PI, for a very long time. And I would also say one other thing here is that no one asked my guidance about how to set the policy, but I have noticed as a private person, interested observer, but still an observer, that Part B premiums have actually been increases in the past have been lower than what I would have thought. You see what I'm saying? So I'm saying that maybe some of this has to do with catch up due to prior suppression. And there are other very technical rules. When there's no inflation, there's something called hold harmless, in which case what you have are limitations on the Part B increase. So a long time ago, when you had what seems like decades ago, but wasn't, you had very, very low interest rates and the inflation, that what would happen is people's Part B increases were suppressed.
Yeah. And then just by way of background, your share of the Part B is the government is 75%, and you're paying 25% of the total premium. Is that correct?
Right. That's broadly correct, Bob. And so now you can, like I said, underneath the hood are stresses to every stakeholder. And that's kind of why I start most explanations whenever we start seeing hot takes on social and things like that, or popular or unpopular opinions being, widely publicized or in print or whatever it would be, that if it were that easy, then I'll be able to point out other facts of, well, then why is this true?
Yeah. Well, I'm going to let you get back on track, but I'll leave you with this one comment. I've calculated, based on the estimated increase in Part B premiums, that roughly 4 million people will fall into the hold harmless camp for 2026.
Right.
Roughly, based on current COLA projections and Part B premium increases.
Because of that, I mentioned a list of ones that are commonly known. So here I introduce different Part B premiums based on income. So this is, in effect, what an economist would call a tax, right? A progressive tax, which is higher income, higher premium, higher cost. So we do not yet know what 2026 premiums are going to be. We expect it certainly over the next, no, I shouldn't say certainly in today's day and age. In the past, if we use the past as a guide, then I would probably call it within the next 30 days or so, give or take. With government shutdown, whether or not that's affecting the release is unknown. The important thing here is modified adjusted gross income 2 years prior. You can see there that I put a star. So in the past, I've written for a research note for the Alliance for Lifetime Income. I use it basically as a guidepost, a reference point that of my own work, which is out there and not, they took out the typos. Thank you to them and the editors, because on the newsletter I pointed out, and in my book, there's probably a typo or something. But my point here is that they're using not exactly the number you're filing on your tax form. Not exactly. And notably here, especially in light of the One Big Beautiful Bill Act, is that while it's being touted as a reduction in Social Security tax, what it actually is a raising of the standard deduction for people at a particular age. The ripple effect here is that the Social Security tax, the amount that is not taxed, is included in this star. So like I said, it's not precisely the number you're using when you fill out your tax form. Obviously, pretty deep in the weeds here. You'll want to, but you can see the reason I'm raising the awareness, and now you can understand why I'm slowing now again and re-mentioning the idea about the financial planning aspect, is you're $1 over. You're $1 over $167,000 as a household or as an individual. You've now invited, right? You've now invited not only the extra income tax for this extra dollar, but you've also now dominated by the fact that your Part B premium is higher and your Part D premium is higher, both. So for this extra dollar of income, you now get taxed many, many, many times more than that. A different setup, like I said in the text on the right-hand side here, this is the Part B alone. So what we have, and it's actually, I think it has typos there, meaning that the premium, this structure is unchanged, the way it works, right? In other words, you've got an annual deductible, you pay 20% of an approved amount. And we're going to discuss approved amount. That is the key part here. Approved amount, I would call, was basically the laundry list of possible services. It is indexed by your location. Right? You have a reference price, MSRP list is the way I describe it. The issue is that in San Francisco, my joint replacement is going to be higher. I shouldn't say lower. Of course, they would know that in San Francisco, it would be expected to be higher than in the middle of Nebraska. Medicare will pay 20% of that number. You're responsible. Medicare will pay 80%. You're responsible for 20%. Now, the question is whether or not this charge and whether you're going to be charged the Part B excess. This will be the implication here, because this is fairly known, right? Which is that this is a structure that I don't use a lot of time, because people are aware of this structure generally from their individual health insurance or from their employer-sponsored insurance, right? You have a deductible. It's much, much lower than you'll find in the private market. And then once you meet it, then Medicare pays 80, you pay 20. That part is known. What's not known is this, which is in individual plan land, this is called balanced billing, right, if you will. So there's a reference price, then there's the actual price under Part B. Difference will be something called the Part B excess. And there's a limit, which is 15 higher than the approved amount. So I've changed this slide slightly from the past. Certain states don't allow this. Certain states do not allow this. And as a result of this, you may think to yourself, okay, well, I don't have to worry about this. I don't have to worry about this. Well, the issue is this index of prices is just higher. So this is one of the situations that may give people comfort. I'm not also saying that as a result, overall healthcare costs are lower in those states. I'm not going to make that conclusion, right? Because the index of this laundry list of prices, this MSRP list that I told people existed, can also be adjusted. And the reason I bring this up is, and now you can understand why I started with something that sounds like it was completely unrelated. Why is Jay droning on about this setup? Well, now you can see kind of the ripple effects, right? Because one of them is that Medicare is cutting payments to doctors, right? That in real terms, if the president of American Medical Association were here, he would absolutely say that, which is not only in nominal terms have doctors taken decreases in payments on their MSRP of this laundry list of services that they provide, but inflation adjusted, pretty shocking numbers. The reason I've slowed down here is that, and Bob, you've got children who are not necessarily, considering jobs as physicians or that as their vocation. But the reality is they're going to come out on the back end and become primary care physician in a small town. You now understand the shortage immediately, because now they have hundreds of thousands of dollars of medical debt, of educational debt that they have to deal with at a time that the primary payer is pushing down their compensation. This is a combination that doctors may find untenable.
Yeah. Jay, just as an aside, or tied to this is this notion that we often tell people to ask if their doctor does accept Medicare, and increasingly more and more doctors are not. Is that fair to say?
What I'm going to say is I'm not judging what the likelihood of yes or no to be. I'm just saying when I try to consider all of the noise, the deafening noise at time, I just simply say, okay, let's switch roles. And what would you do? Mm-hmm. So now that's why I used you, Bob, and said, okay, your child is minus $200,000 living in a town as a primary care physician of 10,000, 5,000. The educational debt collector is still asking for their payment.
Yeah.
Is the candid reality. Yeah. So I'll let people decide whether or not that is assigned a higher probability. We'll get to that, or I'll refer to it when we discuss Medigap later. In summary, I would have called A and B all of that, all of the noise and confusion, what's covered, what isn't. The reason we've spent more time about the enrollment portion as opposed to the coverage portion is because ultimately Part A, Part B is a very good chassis to a car. It's the everyday analogy. Very good. Why? You can see it there in the first two bullet points, which is that the premium on Part A is zero. The premium on Part B, even with the increases, for example, if you're 60, and I use this example when I present in public, I should stop that because this is in public, just a different forum, media. But my point is that if you're 64.9 years old and you're buying individual health insurance for yourself, you're looking at 4 digits a month, easily. There's no plan which wears 80% to 80-20, for example. That doesn't exist. Your deductible is many thousands of dollars unless you have platinum. Well, if you have platinum, the first digit of your monthly insurance, you're $1,500 a month easily, and more than that in many locations. So I don't want to be negative, and I'm not negative. And the Part A and Part B to be a very, very good chassis to a car. That said, number one drawback is this third bullet point. While it is good, it by itself, it has no annual out-of-pocket limit. And that the implication there is unlimited downside. I mentioned the fact that I had knee replacement followed by appendix removal, right? Nothing stops me from having unlimited a number of deductibles. And 20%, even under Part B, 20% of $1 billion is still $200 million, right? Without limit, right? And I use extreme examples intentionally. To address that now you can understand Medigap, Medicare Advantage, which we're going to get to discussing after in a few moments. But my point here is the primary function here for me as a financial person will tell you that it is to have a known cap on the actual medical expenses. I'm not talking about long-term care. Medicare doesn't talk about long-term care. When I'm talking about hospital costs, for example, seeing the doctor, having therapies of different sort, that can be cancer therapy, for example. That here under Medigap, once you meet the Part B deductible, we'll get to the coverage. There'll be no payments. Under Medicare Advantage, there will be payments that you will get line item costs, but there will be a maximum after which you are not responsible for any. Okay, so my main takeaway here is most of my energy when I'm dealing with our clients is to make sure they understand the timeline of the enrollment of precisely what they're doing and why. Right? Meaning under what situations, give them the comfort that they're not missing or they're not subject to any enrollment penalties, giving them the optimal timing for financial reasons and for access to Medicare coverage under conditions that they would like, that fit their household situation. And we cannot, obviously detail every, possible combination, countless. Before we get to Medicare Advantage and Medicare and Part Medigap, I'm going to swerve to prescription plan. So what happened? I've called it Part D, but it's really prescription benefits, which also includes the prescription benefits embedded inside of a Medicare Advantage plan. I've said this is a financial contract. The key point here and key concept I tell people about Part D is, and the reason I start with Part D and not Medicare Advantage, I'm introducing this idea of annual contract. Bob, you and I have what, like you said, one Bob year, but actual 5 to 7 calendar years of comments here, that this is the key takeaway, that this is annual contract. That means all of the complicated terms, all of them, every single one under a legal contract is subject to change every year. So I tell people, and that's the point of Jay's Corner, which is like, look, just use your common sense here, right? What is the likelihood that your 2020 Toyota Camry is the best model at that price class this year? It's almost, if it were, that would be the random event or luck, right? In other words, I'm very sure that Honda, Hyundai, Ford, VW were not asleep at the wheels. Toyota made their own improvements. The world had changed. Technology changed. They made adjustments. Of course they did. That would just be common sense. This is not, we don't need any of my background or degrees for any of this to understand this. From there, these are the details, right? So these 3 terms, premium, copay, formulary, many people know what they are. Premium, the monthly payment. Copayment is a fixed price per tier of medication. Or coinsurance, which is a fixed percentage. And then formulary, which is the approved drug list. This year, well, the reality is we have this every year. This year is going to be a more extreme year. So when I've said that healthcare delivery is so so complicated. 5 years ago, and I looked at it and made a broadcast for public, which is that this year, just to give you an example, in Cook County, Chicago, prescription plans. 5 years ago, that number would have been 30 plus. In other words, to tell you how complicated it is underneath the hood, 2/3 of the participants have left the market. Your first question here today, Bob, for example, and this is why I wanted to have that conversation or hear that question. I saw the question in the chat. I want to address it even before we got to this point. It's more an example of what has happened. And this is why I'm slowing down again. And it's a positive thing. It's actually not a negative, which is that I understand that the attention is on the negative story. But just as an illustration of how difficult it is, it's difficult for everyone. It's complicated for everyone. It's not only the buyer, the consumer. But like I said, if the money were free, if it were that easy to make, there are not 12 competitors, there are 1,200 competitors. But in fact, the number of suppliers, sellers, has shrunk. Minnesota's case, that person wrote about Blue Cross Blue Shield, the second largest carrier of Medicare Advantage plans in Minnesota has left the market entirely. Just turn the off switch. Entirely. Full stop. They didn't reduce the number of plans. They didn't any of this. They said, no, we're done. And in fact, in Kansas, Blue Cross Blue Shield itself, Blue Cross Blue Shield doesn't offer Medicare Advantage to the state of Kansas. These are examples that should counterbalance. So if you hear incidents of this or that horror story, I'm not saying that it's untrue, right? I'm not saying that. And, we help people in trying to understand why this has happened, our own client base saying, okay, why did this happen? Why did this happen? That there are elements of truth in there that I can understand how unsettling it is. The idea that is systematically, this guy's ripping me off, the carrier's ripping me off, my agent's ripping me, I find that very difficult to conclude that. That's not to say your individual instance, there can be exceptions. That I can completely understand.
So a lot of people are going to do a renewal and they're finding that their provider has left the state.
Sure. They've received, like, for example, the chat, the person from Minnesota in that particular instance, that was an example.
Yeah.
Which is in Blue Cross Blue Shield of Blue Cross Blue Shield of Minnesota, like the dominant, most highly known name of health insurance
in the whole country, probably
in the state, right? Well, those aren't the same equity owners, but so their Blue Cross Blue Shield of Michigan is not the same as Blue Cross Blue Shield of Minnesota.
Yeah.
But away from, corp equity ownership 301, the point is that here, it just as an illustration, an example, right? That ultimately they couldn't make the numbers work. They couldn't like even down to zero. And I'm going to tell you something that I want to say that I read in passing. I didn't examine it, that Blue Cross Blue Shield of Michigan last year had operating loss, like the entirety.
Yeah.
So, and this is not a pity party for them or anybody. Well, other than me, of course, but I self-selected, continuing with Maximize Your Medicare. Part D, there will still be confusion. It is confusion, but is still overall positive for the buyer. Again, the deductible is higher in 2026, $615, as you can read. That is correct. That is known. Your individual plan can override it and make it lower. They cannot override it and make it higher. The out-of-pocket maximum limit in 2026 is increased to $2,100. It is in this year $2,000. This does not include your monthly premium. This is your out-of-pocket after you end up paying your premium. Your costs can vary widely. So underneath the hood here are certain facts that don't get widely told to people. That if you use Medicare Plan Finder, if you go and ask me, for example, and somebody comes to me with a list of medications, and we have preferred pharmacies, and we are told, and we would tell people to use your preferred pharmacy. That is true. It is additionally true that every line item inside those preferred pharmacies do not handle every medication exactly the same. And now you can hear how complicated it is. It may not matter if your medication is, let's call it metformin, or, in other words, and for people who are not diabetic or have high sugar, metformin is very common medication and very inexpensive. In fact, I want to say that Walmart or Myers or something like that is like giving it away, like literally giving it away. But when you get to a more expensive medication, that even if pharmacy 1 and pharmacy 2 both are preferred pharmacy, that does not necessarily mean that when you go up to the counter that you pay the same price, even if the plan has stayed the same and they're both preferred pharmacies. So just a money saving tip for some.
So Jay, let me just to be clear. So I'm not locked into preferred pharmacy 1 when I select my Part D plan. I could choose pharmacy 1 for one drug and pharmacy 2 for the other drug.
Administratively, Bob, that can be a little bit complicated. I'm not going to say, right? I'm not going to tell persons that it's worth the legwork, etc. They may just decide, look, I'll just take the overall lowest cost pharmacy. But what I am going to say is that even the overall sums between two preferred pharmacies, they can both be preferred and not have the same out-of-pocket cost. That is entirely possible.
Yeah. Well, I can tell you my mother, when she was alive, would go from grocery store to grocery store to grocery store with different coupons. So she would be in that camp that would gladly go from pharmacy 1 to pharmacy 2 just for the savings.
We're not talking about the ACA today, but the reality is if you're on very expensive medication and prior to 65, that is and you have high cost medications, that is absolutely your month to month exercise. Yeah. And that would make hundreds of dollars a month difference. Hundreds of dollars a month. Absolutely. Again, we're not going to resolve all of these things here. All I know is I'm to blame. That's kind of what my inbox says. But if we just continue here, that I've made the point about the two pharmacies. These last two are known. I mean, no, they're written down. They're stated. It is confusing. So insulin capped at $35 is kind of the headline. The issue is that there are many different types of insulin. Slow acting, fast acting. I'm not a medical doctor. I don't know any about it, but I'm told that there are many. I know there are many different brands and manufacturers of insulin. Let's leave it there. The point is your specific variation must be covered by your plan. It is not that, for example, if you got insulin X, you don't get to take under that thought. If it's not covered by your Part D plan, you don't get this $35 cap. So you'd be wanting, because when you combine that with every detail moves every year, just because your insulin was covered in 2025 does not necessarily mean the same will be in 2026. Every part move every year. And the same, more topical probably because newer, GLP is the same. Two things. You need to have a medical reason, right? Just because, I aspire to be a runway model, that is not the reason that I can be covered by my Part D plan for weight loss by itself. It needs to have a medical reason.
Jay, before you go to the next slide, can I interrupt one more time at the risk of making you old?
Please.
You mentioned within the case of insulin that has to be covered by the plan. My understanding is with the $2,100 cap, that's only for drugs that are covered by your Part D plan that are in the formulary. If it's not in the formulary, that cap doesn't apply.
It's an excellent point. Yes, that this 20, Bob, that I, and then show speed, basically what end up, yes, this 2,100 only presumes that of the out-of-pocket costs of covered drugs underneath your plan, of covered medications. So I don't get to bring my medication that my voodoo doctor, and be subject to the 2,100. That's right. If you go for example, some people, for whatever reason, they get their medication if they go to another country, not going to be subject to the 21. I'm not going to spend much time on this other than but I want to show it up on the screen here for people that I appreciate all audiences from every background, and also this, which is not enough people who qualify for Part D assistance use it. They don't access it. There are stunning statistics. KFF has them. I don't have them off the top of my head. But the issue is there's extra help that is not Medicaid. Okay, so Medicaid is complicated, but so the way it works is if you're qualify for Medicaid, you certainly qualify for extra help, not the other way around. Means that you can qualify for extra help for prescription drug costs and also not qualify, but yet not qualify for Medicaid. That leaves a fair number of people who are stretched but don't qualify for Medicaid, who are not getting this extra help, even though these programs exist. What does this do? It lowers your premium. And this year, we have notably higher premiums. In addition to that, it has lower copays for particular medications. Entry into extra help is going to be more complicated. In other words, you can see this is expanded in 2025 in 2025. It is back down for 2026, which is not part of this slide. In addition to that, down here is a very important couple of points here, which is that, let's say, for example, and you'll know this person who feels stretched and doesn't know the rules, or said, I know the rules, but I'm too afraid to sign up because I don't have the money to enroll. They've now started the late enrollment penalty ticker. Now the time clock has begun. 3 years have passed. If they qualify for extra help, which is not necessarily Medicaid, but extra help, then the late enrollment penalty is waived. Late enrollment penalties get waived. So please, my point is that I've slowed down here intentionally. When I'm talking about these financial assistance programs, it may not apply to you directly. I find it very low probability event that no one you know doesn't have the right or access to it and should. I'm going to move to Medigap, Medicare Advantage. Medigap first. And rather than talk about the higher premium, these are all true of facts, right? Higher premiums, superior cost sharing, meaning that you'll see it here. Please don't squint and write things down. This is all publicly known information. If there's an X there, it is covered. It is summarized verbally this way. Higher premiums, superior cost sharing, meaning that once you beat, in most cases, once you meet the Part B deductible, these full X's means covered in full. So you don't have to see what these are, but you can. So the Part A deductibles for the knee replacement and then my appendix being removed. Covered in every instance. So, for example. Okay. The issue here is coverage. The reason, this is the main thing, which is there's no network. Any party that takes federal Medicare will accept your Medigap plan. Very importantly, let's make sure that your billing person of the day doesn't mistakenly identify Medigap as if it were Medicare Advantage. I'm not dreaming of this. This happens. Hospital billing office looks at your card, knows it as a Medicare Advantage carrier, and says, we don't take this card. And then I get a panicked call. I said, go back to them and tell them this is not Medicare Advantage, this is Medigap. And to give you an idea, back in the day, how do I know this happens? Because my mother is the friend of primary care physician practice in our circle, and a client told me about that office. That client, his Medigap plan was rejected by that medical office. I called. They don't know me from Adam. They said, who is this guy? He sounds crazy. Click. I had to have my mother make the call to rectify the situation, say, well, yeah, he's just some guy, but he also knows about this matter. Maybe you should pick it. Then I get the call from the billing office to resolve it. Meaning that this kind of error in identification does happen. It happens every year. Under Medigap, I would tell you the following two. Standardized, grandfathered. By standardized, it means Bob's Insurance Company and Titus Insurance Company Plan N. They're the same down to the letter. That's it. There's no difference in coverage. They're not kind of sort of the same. They are precisely the same. Legal contract written with precision. While they're standardized, the premium can change at different rates. And every year I get this email with people smarter than I who have studied this and try to use lots of time. And then I talk to certain other people and I explain in a couple of words. The sellers have perfect information, and all the sellers know that all their competitors have perfect information. They may have their own commercial reason for trying to be more aggressive or less aggressive within boundaries. The idea that we are going to know this in advance and guess at it in advance, I find unlikely would be the kindest possible way for me to describe it. I don't use any energy to be candid. I don't spend any time trying to predict what the carrier's rate of increase is going to be unless they intentionally are letting in people with lower underwriting standard. And even then, it's not a guarantee. Right? When I said this is a probability matter, this is a probability-based matter with variance and then commercial design on top, meaning commercial intentional strategy in particular locations. I'm not going to name where those states are and the carriers are. I'll identify it every single year. That a particular carrier, and I'm slowing it down, and for this particular audience, this is not the kind of thing that I say at the senior center, which is the particular carrier definitely chooses particular states at different years. Definitely. It happens, and it makes complete logical commercial sense. I don't have a presence in one location. I need to have one. It's a top priority for me as a company. So what did I did? I tweaked I became super aggressive in price because on the high end, I'm bounded by regulatory restraint in terms of price increases later. I'm called MLR, medical loss ratio. There are guardrails, but what ends up happening is some carrier does air quotes buy business by becoming uber aggressive in a particular location in different time periods. Yes, it happens every year. That's why I know it's not a coincidence. And I've sat in the seat of not insurance carriers, but sellers at large of financial products. It makes complete common sense. I've gone on a tangent. I'll get back on track here. Grandfathered. What does it mean? It means that 2027, 2028, 2029, and the future, your coverage does not change. Your premium changes, not your coverage. The carrier has no leeway to change your coverage. Okay? These are financial contracts. Sellers have no choice once the contract is completed. And for that, that is a great sense of stability, right? If insurance is to purchase stability, right? Alliance for Lifetime Income, like I said, the Research Income Institute, those people call this the license, and those, I don't mean, they're not evil. My point is they're more to spend. Well, insurance is also a license to spend.
So, Jay, just one quick question. I forget the exact number of states where they don't offer that full menu of Medigap plans. I know Massachusetts is one of them, but there are others where you have 2 or 3 plans to choose from.
Yes, that's right. I've given the standardized national set.
Yeah.
So there are a couple of states where the configuration is slightly different. Wisconsin being one, for example, where some of these line items must be included inside of Medigap plans, and you can a la carte purchase other line items here. Okay, so you do have this situation, and beyond today it actually is very they prove my point about certain of the details that I've touched on here today. And beyond more than that, before we're now in a 5-hour podcast. But let me just say that, yes, there are certain locations that have plans that don't look precisely like this, in which beyond the scope of today, but yes, that can exist. It's not many. Yeah. It is not many. Your right to entry does, in Massachusetts, is one of the exceptions, but this is for sure true, which is that when Mr. Smith's Part B begins, that is the beginning of a 6-month period in which nobody can say no for any reason, full stop. So it's not when you turn 65, it's when Part B is turned on. And that's a nuance that may not seem relevant, but it will become relevant in a moment. But the implication here is the buyers have unlimited options. It can shop for price if it would like. I don't, not on the slide. I don't use price only privately for our client base. Price, of course, very, very important. But because the world is so competitive, to give you an idea, even in Tampa, in Pinellas County, I looked at a price today. I found 3 carriers at basically a tie that were not 65. So it gives you an idea, even with different populations, etc. In a particular county. Pinellas obviously heavily populated with the Medicare population in the greater Tampa area. What you will have is intense competition, not competition, intense competition. Adjective important here. The window doesn't last forever. It lasts for 6 months. Okay. The main thing is about these next two panels. If your other coverage ends, so you've retired, your large employer plan ends, they don't have retiree health benefits. In that case, that's a situation that you're not covered. Your employer is not extending you. You don't have the right to it. If you're canceled by your employer, for example, you are federally protected. Why? Because you're going to turn on Part B at that time. Let's say you didn't enroll in Part B. But if it's canceled by your employer for whatever reason, you are federally protected. Meaning you can get into Medigap either by the fact that you have the open enrollment period or a special enrollment period because of the fact that the employer was the party that canceled. If you are electively canceling by you and you're covered and you are already covered by Part B, it is very complicated. And I'm slowing down here because this is an exceptional case that I'm very sure is misunderstood. What can happen here is people that say, I don't know this Jay guy. I've ignored all the stuff. I'm still working full time. I'm going to have Part A and Part B. And then I stop working, right? Because I'm at a large employer. My large employer only charged me like $10 a month for my health insurance to be covered. I'll just stay with that. So I have Part B, and on my large employer is first at $10 a month, and Medicare, that's fine. At least I've avoided the late enrollment penalty under Part B, which I've misunderstood, but I've done it anyway. The issue here is that when you then stop working because you retired, meaning you've canceled, right? Because at that point in time, you need to understand that that was canceled by you, and that is not federally protected. That depending on your location, the state may require it, not the federal government. So in state 1, my answer would be X. In state 3, my answer will be Y. So now let's just say you live in a state where that's not federally protected. The carrier can choose to still allow it in that instance. So now you can see this is not just 1 or 2 criteria. This is multi-layer, multi-criteria, multi-situational on what happens when you stop working and what your existing coverage is. Your base case is that you take Part A, assuming that you don't have the HSA matter that we discussed. Newcomers, you can go back there. You don't take Part B at a large employer because your large employer is primary. And the secondary reason here is so that you avoid any conflict of this Medigap acceptance, because then this still is true, which is this is still an unrestricted right. So we literally could have an entire podcast about this particular slide. You can now understand why I'm happy to provide information to make things as clear as possible. You can also understand why I stopped very short of the line of saying that executing yourself does not sound like a great idea. Let me just, which really very kind of me to say in the kindest way. I can speak kindly at times, which is that we started this conversation about all of the different steps that need to be taken, even to get your federal card in place. And now we've got a second set here of dealing with Medigap, for example. We'll have another one with Part D and Medicare Advantage, right? Actual execution of these steps. And for better or worse, I'm on social media making posts, and invariably I'll say, I don't need you, Jay. I can just do it myself. It's simple. You live in a state, you had Part B, you thought that you could just go in here because that's what your friend did when he stopped. You don't have the same situation. You've gone to a carrier, the specific carrier who said no. When I got them in because I knew that particular carrier was electively allowing. This happens. And that sounds like crazy. You might say like this person is like crazy. These combinations exist. And that's what I was saying, like here, this is at this last point, right? This is not reasonable for the reason I was talked about this is a very good illustration. It is not reasonable for a consumer to keep track of these combinations that I've just spewed out without a script. This is not the complete set either, because it varies by state and carrier, and or carrier, or combinations of carriers, etc. And now we've got 10 carriers. Let's say, for example, we're not trying for a guaranteed path or a federally protected path. I actually prefer federally protected because one's the open enrollment period, one is special in enrollment period. Both are federally protected. Is my point, right? Let's say you don't have these protections. You've got then seller in control. That's it. That's your key. They can say yes or no for whatever reason they want. They may tell you in advance, these are definitely no. They're not going to they are not required to say, if you meet all of these, then you're definitely yes. You could have some other line item in your medical history. Different carriers could assign you different rates. So I tell persons, if you're in perfect health, if you're Miss Perfect, Mr. Perfect, it's not going to be a problem. No medications, never looked at a beer. It's totally fine, right? BMI, of course, being one. Imperfect health is the question. Questions? They're going to judge differently. Their relative difficulty is going to change. Their relative position is not going to be told to you. It's nowhere in paper. They're not required to. Historically, will I know some idea about who has been an easier grader than others? The answer is yes. Am I going to tell you in what order and for what reasons under which situation? The answer is no. Am I choosing only on price? The answer is no. Right? Because price is true and of course primary always on, especially I've told you that things are standardized. So the easy thing is, okay, well, if it's completely standardized and grandfathered, you're just on price alone. Well, now I've told you like, oh, well, the price of one versus price of number two is literally a penny a month. And there's some other aspect that I have experience with on a particular carrier that didn't exist over here. Maybe you have to pay 12 cents a year more. In other words, there could be a reason. People don't understand that the market is this competitive. So as a result, they just say the price dominates because they think that the second place price is 15% different. No, it's 15 cents different. Yeah, it's a little different. Medicare Advantage is here. Yes, I figured we were on tangent, so we would go over. But we are approaching the end. Medicare Advantage Part C, annual contract. You can see in the middle panel, the first bullet point, annual contract. So all the implications and the windup for about Part D all exist right here. Annual contract means separate cost sharing, separate networks. Some exist with or without prescription drug plans. Please be careful. Okay. What you ultimately have here is cost versus moving target, meaning that in certain cases, there's no additional premium. You do need to be enrolled in Part A and Part B. Okay. But you have a cost versus moving target. So you have a lower premium, but on the back end, if you are a heavy user of healthcare services, you are going to have itemized bills. I didn't say that the itemized bills would exceed Medicare Medigap. It could. It could. So if you're a person who goes to a high-cost doctor and that person under Medicare Advantage costs a very high amount of out-of-pocket cost per appointment, can the stack of those invoices for the appointments exceed Medigap? In theory, the answer is yes. Especially when combined with inpatient hospitalization, because like I said, every detail will change for every plan. The amount of dollars per day for inpatient hospital stay, the amount of money that it will cost for an MRI. If you have cataract surgery under Medicare Advantage, there will be different price points. And when you add these different numbers up, can it exceed Medigap? The answer is yes. Is it always the case? The answer is no. So Mr. or Miss Perfect, they never go to the doctor. They have the card for the sense of security alone. And that person lives on Social Security alone, which describes 20 million, depending on your data source, right? You can understand if you're Mr. Perfect or Miss Perfect, or if you are that stretched financially, I categorically reject the conclusion of never Medicare Advantage. That person, that extra money is food, right? So this is the negatives that you see about Medicare Advantage. I can understand. It is complicated. Why? Because this is annual contract, and this carrier gets to determine what the terms and conditions of the annual contract are. That is true. It can also be true that the money saved is that important to that household. That's my only point. And that the negatives here come from a different set of sources. Some are correct. I have no doubt about this. Hiccups on prior authorization, for example. Sure. Does that override the idea that, okay, I needed to pay for groceries? That is up for the consumer to decide. That is not up for Mr. Hot Take, which is not me, but you can understand. My point is the person out there standing on, okay, never this, never that. I just find that I find that disserving to the people who depend on and can rely on Medicare Advantage contract. Carrier is going to follow the contract. These are approved by a federal government.
Jay, just as an aside, every time we talk, and every time I talk to any financial planner and ask a question to a specific item, the answer invariably always starts with it depends. So there are no shoulds in a way, right? The only should is that it depends.
Yeah, I would definitely say so. I would say that there are certain people who you can easily see that, for example, if you live in South Beach and you're 85, your Medigap plan is $500, $450 plus a month. If you multiply it by 12, and there's lots of fun stuff to do in Miami. And if you're Mr. Perfect, you may want to use, or Miss Perfect, you may want to use the money for other things as opposed. Or maybe, for example, or the cost of living very high. As a result, you're crowded out. This is complicated. I'm not disputing that. I do tell people that when they face this, that privately, I tell people, my first question then becomes, is there a responsible adult around you who can be on the same page? Like, as a practical matter, I've talked to a couple of people. We'll see some videos in the next coming days, for example, that we're talking about cognitive decline. When you're talking about aging, people have said, okay, it's unfair that a person in their late 70s, their 70s, have to make these difficult decisions. When it comes to Medicare, I get sent persons or people refer themselves to me for a number of different locations. When a 35, 40-year-old adult child comes and says, I'm handling this for my mother, my first statement is, thank you for being involved. Is because that it's for both of our mutual protection, that there's more than one party on the other end. I can understand it's complicated, and some people don't want to, have an adult child involved in some things specific. I'm not. It's not entirely clear whether my mother comes to me for Medicare guidance. I think it depends. She's lecturing me about 5 other topics first, but you can understand my point. I understand it's uncomfortable. By that same token, when it's this complicated and when there are this many moving parts, or you forget, etc., then can be valuable. So this is what I would say. This is a list. We're not going to include it. I'm going to tell you that this is because of all the moving parts and because of all the stresses, you can expect benefits being reduced. Yes. I didn't say eliminated. And to give you an idea on how complicated it can be, is that sometimes the access to dental and vision, for example, is so important and central to someone's healthcare cost list that access to it is best through Medicare Advantage. And now it gets real complicated. That now somebody is, I have a healthcare problem. I have a healthcare problem. My teeth are bad. And that's their sole problem. And I need this, that, and the other. Well, if you ask a dentist, they'll explain to you about how dental insurance and interfaces with their practice, and you will see lots of different other layers. We'll see headlines. It's yet to be seen. I would say that if we have problems, my problem here is that if there is actual evidence and conclusions, the corrective action, the ripple effect, hurts the Medicare population. Just leave that with you. That yes, I can understand that nobody wants companies to be breaking rules systematically with tax dollars. That is 100% understandable. The flip side will be that those benefits that the 80-year-old person who lives on Social Security alone is the one who is going to ultimately pay for the price for this. That is going to be simultaneously true. And that is a tough choice. Well, and policymakers, Sophie's choice, if you will. Now, Bob, you've been on in media. We've discussed this. Can you change? So to the person who asked at the beginning, here's this time, October 15th to December 7th, you have the unrestricted right to elect a Part D plan or any Medicare Advantage plan without limit. If you live in that location and you have original Medicare, you just need either Part A or Part B in order to have a standalone prescription plan. You must have Part A and Part B in order to be 99% of Medicare Advantage plan. There's one exception that is too thin to even mention here. The question is Medicare Advantage to Medigap. Again, order matters. I always tell persons, you want to make that change, that's totally fine. We will guide. That said, you start with Medigap acceptance first. Always first. Now I've broken my rule of never say always, never say never, but Medigap first. Medigap first. Why? Because what happens is when you apply and are accepted to a Part D or Medicare Advantage plan, whatever the incumbent was is ejected. Auto-ejected. So I was on Medicare Advantage plan. I said, oh, I'm just going to go to Medicare Supplement and Part D. So I enroll in Part D first. Your Medicare Advantage plan is gone. It ceases. It's gone on January 1st. So you have Part D, and then 2 weeks later, you get rejected by Medigap. In which case, you don't have Medigap, you have Part D, you don't have Medicare Advantage. It's gone. Meaning, you have Part B alone and Part A alone, which means unlimited downside, as we discussed on original chassis to a car. You are chassis alone. If you find out that one of these moving parts is not great here for you, if you are an existing Medicare Advantage plan member, you can change during the first quarter of next year. There are exceptions. Here they are. You don't get to say that the dog ate my homework, but if you live in a federal disaster area, you can. It'll be stated. You don't get the special exception forever. 5-star enrollment. The number of 5-star Medicare Advantage plans declined precipitously. I will not know what it is for next year yet. You can change into a 5-star plan once a year. We've discussed a lot of this, so I put it there just for review. We're not, especially we've even exceeded. Well, we talked about important other implications and ripple effects here, so it's just more than the pure, Medicare matters. Here it is. In a perfect world, somebody at least 2 years because of the IRMAA question. Right, that's basically your guideline. That's the latest that you all want to think about this. Even if it weren't for, you have maximize your Medicare for 2 years in advance, so you can see the list. It's like, what crazy person would write a 200-page books? A, and then the second one is, okay, here are the list of other moving factors that I have to consider. One of which is related to my taxable income level. I've discussed a lot of these implications here, talking ahead of these slides. Right? Medigap rates becoming painful. We've had this, right? Which is that the person has responsible adult son. I don't have a brother, so I guess that has to be me. My point is that could my mother change to Medicare Advantage? The answer is yes, because I'm there helping administer. Birthday anniversary rule. So this is becoming a growing trend that your Medigap plan, Plan G has increased, and we have seen notable increases. I've stated this, notable. 15% easily. I've seen as high as 30% in a year. That you have the right to change based on a particular set of clauses depending on your state. Now, if this exists, I'm happy to help you exercise the extent of those rules. Just understand that if you're talking to your buddy who had used the birthday rule in state number 1, birthday rule is a generic term. It is not a standardized term. So in state number 3, the terms, conditions of that ability to switch can differ. I talked about the extra help, and so I double down here on Medicaid. In fact, I'm most concerned about the changes to Medicare as a result of this crowd, which is that people are going to be getting switched to different tiers under Medicaid, which will change their eligibility towards these combined plans. And these combined plans, their benefit on the back end changes their standard of living, literally. So now the most disadvantaged crowd is being switched around in a volatile way. And it's not always negative, but my point is without the Medicaid eligible population understanding the implications. So I'm asking the audience, wherever you are, whatever group you belong to of large sets of people, to at least have that population understand, try to get the information wherever it comes from on their status. I've discussed this. This has something to do with the noise. Bob can ask me about in a 3-minute hot take at some other time in the future. But yes, this Medigap premium spike, it has to do with the health care utilization, right? People coming out of the pandemic, every hospital system, every insurance carrier is telling you that utilization higher. Medigap health insurance derivative contract based on healthcare costs. The probability, I said probability based on the use of healthcare services, which cost money. Higher usage, higher overall cost, higher cost of derivative contract. In that order. Not the other way around. My Medigap premium increased. That's what created higher hospital bill. That is the backwards order. And yet somehow, it's the carrier's fault that healthcare costs high in the United States. You've now stated that we are getting the cost of raw oranges from the gallon of Tropicana. That is exactly backwards. That was my soapbox moment for today. Late preparation is obvious. Set it and forget it should also be self-evident. These are just practical reality. What is not necessarily practical reality is blindly believing employer benefits. If you're very ill, let's just say, for example, you're married, full-time working, both above 65, Medicare eligible. I understand that your employer is paying 80% of the premium. That's fine, and your premium is very low. I'm just going to say that if you open the explanation of benefits, it is very likely that Medicare is superior and that your overall cost bill plus access to coverage, right? Because your employer plan, even very high quality ones, are still HMOs or PPOs. Must be. Original Medicare plus Medigap, the number of providers that will accept that configuration is almost unlimited. Blindly, and I would very much double down when I said this on retiree benefits. Underneath the hood, if someone made me the head of HR at the largest employers, I know this is a huge cost. I said, let's find the way for the very observant retiree to compare the retiree benefits to the private market. And I can tell you this, and this is not a negative, me insulting any employer. I can say so for, the best university which happens to be also in Ann Arbor. I'm making fun of my Big Ten little brother. But anyway, jokes aside, my point is that public record, you can see premiums, and the premiums of employer retiree benefits higher than that of Medigap plus Medicare Advantage, and still be a Medicare Advantage plan. So this is not to say that the employer is uncredible. I didn't say that, right? High quality employer. But you're the buyer and you are trying to defend yourself and get the configuration that you need. That can be the combination. We're free. One last thing I would say is that, I have this every year, which is people don't come to us under some weird idea that I'm going to charge. The regulations are that we cannot charge you for pure standalone guidance on any Medicare matter. Okay. Do we professionally charge for matters that are sitting aside? Yes. So in other words, when there's an implication about what the strategy looks like to avoid IRMAA or get the most from your advanced premium tax credit for a particular family, and that means we have to look at other matters, then we would have a one-time fee. Hours unlimited in our instance, or in other words, my counterparts could also then therefore charge. But if you came to us for Part D only, Medicare Advantage only, find me the Medigap carrier, there's no charge for it. And the reason I say this is not to say anything about ourselves. What it really is the rules disallow it. Means that if you're being charged, you can ask for what is this particular charge, right? Because if it's pure brokerage function alone, that would not be part of it. Phew.
Well, Jay, that was a masterclass. I think it's worth noting about your book once again, that you have a Substack and that you also have a YouTube channel where you folks can get sort of I forget how frequently you're publishing to your channel, but they can get updates on all things healthcare.
There are a number the interaction, and I tell this to people in the Substack that I can understand that social media is trying to put us into silos. I am going to say, as a financial planner, and the reason for my my involvement with the Alliance for Lifetime Income, and those people there understand that there's this interaction across these things that look like separate topics, but they are actually interacting with each other. And that the effect of the interaction can be easily bigger than the individual topic itself. And not to mention the other ripple effects, including not only financially, but then on their personal family situation.
Well, this has been an incredibly useful masterclass, I think. I have to imagine that anyone who watched it live or watches it later will become, that much better off for having watched it. So,
if people have questions, they can leave. There will be different avenues to do so. I'll make sure that we're available to answer whatever needed. No problem.
Yeah, I was going to suggest for anybody that's watching this in the archive, please post your questions in the comments, and we'll make sure they get to Jay.
Very good. Thank you so much.
Thank you, Jay. Have a great rest of your day, everyone.
Thanks, Senator.